Now I am coming to the leftover from yesterday's lecture on the arterial line. Now arterial line, you know, it has a waveform. The rate of upstroke is related to the contractility and downstroke rate indicate the peripheral vascular resistance. Systolic pressure variation during the respiratory cycle more than 8 mm correlates strongly with hypovolemia. So if there is systolic pressure variation during the respiratory cycle more than 8 mm, so this corresponds to mostly the hypovolemia. Dampening of arterial tracing. Under-damped systems overestimate the systolic pressure by 15 to 30 mm mercury and amplify the catheter and artifacts or catheter whip. Over-damping refers to a transducer diaphragm or measuring system that is too rigid. Over-damped systems underestimate the systolic pressure and occurs with high viscosity, soft tubing, air bubbles, blood clot, and kinked catheters. Mean pressure are typically less affected. Optimization. The system is optimized by minimizing the tube length less than 120 cm. Eliminating stopcocks and air bubbles using low compliance tubing with internal diameter of 1.5 to 3 mm and using continuous flush with heparinase saline 1 to 3 ml per hour. Assessment of dampening. The engineering and in vitro laboratory gold standard for assessing the accuracy of the dampening coefficient is the square wave test. Several oscillations following a flash occur in the underdamped systems, whereas fewer than 1.5 oscillations following a flash will occur in overdamped areas. Complications of arterial cannulation. Risks are minimized with small catheters, heparinase saline, and continuously infused slowly, 2 to 3 ml per hour. Flushing is minimized, aseptic technique utilized, and pulse oximetry is utilized to continuously assess the perfusion. Complications from arterial cannulations. Vascular and insufficiency and vasospasm, hematoma, blood loss, arterial thrombus, air or thrombotic embolic, nerve damage, infection, intra-arterial drug injection. Now come to the summary of the arterial blood pressure monitoring. Indications: need for instantaneous BP reading. Patients at higher risk for adverse outcome with BP changes, surgical procedure with anticipated fluid shifts, need for multiple blood gas analysis. Mechanics: based on the pressure in the fluid, therefore must zero transducer and place at mid-axillary line or at the level of the brain in the neurologic procedures to monitor the cerebral perfusion pressure. Clinical pulse or clinical important points. Over-dampened system underestimate the systolic pressure and vice versa or under-dampened system. Access site, radial artery is most common, but alternatives include the brachial are possible. Consider use of ultrasound for difficult placements. And thank you. Now we come to the end of the lecture session on arterial invasive BP monitoring.